It is my great privilege to introduce the Chambers Family Lifespan Lectureship. Dr. Heidi Feldman is the Chamber Family's Lifespan Lecturer at this meeting. Hank and Jill Chambers have provided incredible leadership and vision to this organization. As I mentioned yesterday, have really helped the Academy move forward and recognize and appreciate the importance, the critical nature of thinking from a lifespan perspective. Let me tell you a little bit about Dr. Feldman. She's got her MD, PhD, and holds the Ballinger-Swindells Endowed Professorship of Developmental and Behavioral Pediatrics at Stanford University. She serves as medical director of the Mary L. Johnson Developmental and Behavioral Pediatrics clinical programs at Lucile Packard Children's Hospital. She has served as president of the Society for Developmental and Behavioral Pediatrics, program chair of the section of Developmental and Behavioral Pediatrics at the American Academy of Pediatrics. Very accomplished. She is chair of the subboard for Developmental and Behavioral Pediatrics of the American Board of Pediatrics and chair Behavioral and Biobehavioral Studies section of the NICHD. My goodness, you must be busy. She's recently written a book called Redesigning Healthcare for Children with Disabilities. It was published in 2013. And this, as she argues in this book, for a new paradigm for healthcare delivery for children with disabilities across the lifespan. Heidi, we welcome you to the podium.
Well, it is a terrific honor to be before you. I want to thank Darcy and the organizing committee and the Academy. I think I would have chosen a slightly different session with dry and uninteresting speakers before me, because this is indeed a very, very difficult act to follow. I also want to just acknowledge that it's great to be a developmental behavioral pediatrician and be speaking at this conference. So let's go to the next slide, please. Oh, I can do that, yeah. So the one financial disclosure that I have to make is that I earned a small amount of royalties from books publishing for this book on this topic. I don't think that really presents a huge conflict of interest. But I also want you to appreciate that there are a few things about this presentation that I hadn't quite anticipated and are disclaimers if not disclosures. First, I'm very new to your Academy, and as I've sat through sessions over the last couple of days, I realized that a lot of the points that I'm going to make are very familiar to many of you in the audience. So for some of you, this may be old news or confirmatory. I hope for some of you it's new news or maybe even a bit provocative. The second is that I didn't realize at the American Academy of Cerebral Palsy and Developmental Medicine there would be such a great representation of people from other countries. So this talk is very much from a US perspective. I hope that some of the changes in healthcare delivery and healthcare reform that we're going through in the US now can be useful in other countries as well. And finally, I want to thank the Chambers family for the opportunity to speak here, and I'm so delighted that I had a chance to meet them in their beautiful home last night. What I decided to do is integrate issues about youth and young adults throughout the talk rather than create separate sections, because in general that's the way I think we all work with integration. So with that in mind, there are four major points that I want to make today. The first is that children and youth and young adults with disabilities should be conceptualized as a category from the standpoint of healthcare delivery and healthcare reform. Second, healthcare for children and youth with disabilities must primarily support inclusion and contribution. Health is our means to an end. I think we're designed in many ways to do that, and we can get better. Number three, the Patient Protection and Affordable Care Act of 2010 in the United States, known affectionately as Obamacare, brings many advantages but also several challenges to healthcare delivery for our patients and their families. And so point number four, we as clinicians must preserve what's good in what we've been doing, must improve our clinical approaches so that they're consistent with new laws and regulations, and must remain politically active so we can continue to craft healthcare delivery in a way that's helpful to our patients and their families. So let's begin with some definitions so we're all on the same page. This is children, youth, and young adults with disabilities, and this is the audience participation part of the talk. So, does this individual have a disability? This is a 20-year-old veteran from the Afghanistan war. He had lower limb amputations. He has phantom pain. He's relearning to walk with his prostheses. He also suffered traumatic brain injury, which disrupts his working memory, increases his emotional lability. And with all of these issues, he's previously lived independently, but now has returned to his parents. So by a show of hands, how many people think he has a disability? Most hands go up. Anybody who thinks this does not qualify as a disability? No hands go up. Okay, how about this individual? Another 22-year-old young adult with Down syndrome. As an infant, he had congenital heart disease that was surgically corrected. At school age, he was participating in special education, and he tested in the mild range of intellectual disability. How many people think this individual has a disability? And most hands go up. Does anybody change their mind if I tell you he works doing filing and clerical chores in a law office, and he lives in his own apartment with minimal community-based supports and services to help him function in everyday life? Anybody want to change their mind? No hands, well, a couple hands go up. How about this individual? This is a 22-year-old who was born at 25 weeks gestation. She had the alphabet soup of complications: respiratory distress syndrome, patent ductus arteriosus, and a grade 3 intraventricular hemorrhage. At 2, she was delayed in walking, asymmetric in tone and reflexes, and she was diagnosed with cerebral palsy. Does she have a disability? Hands go up. Does anybody change their mind if we find out at school age she's ambulatory without devices? Still think she has a disability. And then she graduated from a small college and teaches the first grade. Any changes? Okay, final case. A 22-year-old college junior, no major physical health conditions. He experienced a major depressive episode at age 15 years and was treated with cognitive behavior therapy. A second depressive episode occurred when he was 17 years of age, and he was treated with medication, selective serotonin reuptake inhibitors, for 5 years, and he had no recurrence of his depression. Does this individual have a disability? Hands up. Looks like a few hands are up. Off medication at age 22, his depression recurred. And then he was restarted on medication and his symptoms subsided. Disability, hands up? Okay. So I hope that you're experiencing some discomfort, and I think it's because we really have to look at this from very different perspectives. Sometimes, and in many sessions at this meeting, we're looking at conditions through a microscope. We're trying to understand the biochemical or genetic cause, and we're trying to fashion very specific interventions for various conditions. At certain times, I think it's better to look at conditions through a wide-angle lens. And I think particularly as we move to issues of healthcare delivery and healthcare reform, it's important to take a step back and look at the broader field. So in the category of disability, up until the 1990s, we used to think about disabilities as just the presence of one of a series of conditions that was on a list somewhere or another, maybe in the Social Security Administration. And then in 1998, McPherson and colleagues from the Maternal Child Health Bureau published this definition of children or youth with special health care needs. And there were two major criteria to say that children should be categorized as having a special health care need. One was that they had a long-term condition. It could be physical, developmental, behavioral, or emotional, and that they typically required increased levels of healthcare or related services and other supports. So suddenly, when this group was brought together, there were the opportunities to do epidemiologic studies and also opportunities to fashion patterns of healthcare that could be useful to broad categories of children. Individuals with disabilities usually are defined as those who meet the first two criteria, but have a third criterion, which is that they experience challenges in their ability to function within the environment. Those challenges can be present, or they could be ameliorated by either medications or ongoing services and supports, but without those medication services or supports, the limitations would again recur. And a lot of studies look at what the relationship is between individuals with disabilities and individuals with special healthcare needs, and you can read 60 to 90% of people with the long-term health conditions also have disabilities. So did the individuals in the various case scenarios have disability? I would answer yes, but they might not self-describe as having disabilities. I think we could really think about whether or not these are the best terms to use, whether it's important to lump the various criteria together. Maybe we should talk about long-term conditions and functional challenges. But for right now, I think the term disability is important for our planning purposes. And so why is it important to categorize this group as such? I think there's several reasons. First, when we do that, we find that the group has very high prevalence. They have high complexity of medical needs and related needs. They have high healthcare utilization and cost. They face similar challenges in the healthcare system, and they're likely to benefit from similar strategies in healthcare delivery and reform. So let me just back that up with some data. In the adult population, again, you can read a lot of variation in this, but across the age span from about 21 into older adult, the estimate is that almost 1 in 5 individuals have a disability. In childhood, it's actually not all that different. The figures go from about 19% to about 15%. So this is a really big group. That translates to almost 55 million adults or people in the US, 10 million children. The proportions are on the rise, even in the last 10 years, but particularly over the last 40 years. And 25% of US households, regardless of income, have a member with a disability. I like to think about this when I go to a big wedding, big family wedding, and just kind of take stock. Worldwide, we heard some figures this morning. The figure that I've been able to find is 650 million people have a disability. High complexity can be reflected in many different ways. Here's one way. If you have one disability, what's the probability you have a second disability? You have multiple problems. And adults, almost half of the individuals who have one disability have other disabilities. In children, again, it's higher than I would have expected. It's over a quarter of children have more than one disability. And the complexity, of course, is not just medical or healthcare complexity. There's also social and financial and economic complexity. For example, the prevalence of disabilities is higher among individuals who are poor or members of racial and ethnic minorities than it is among the wealthy or the racial and ethnic majorities. And not only that, but disabilities and other long-term health conditions may lead to reduced income for both the individuals themselves and also for their families, and that may in turn lead to lower socioeconomic status. Meanwhile, there's high healthcare utilization and high healthcare costs. Here's a table that was based on US data, and you can see that as the service needs are more complex, like hospitalization versus doctor visits, the comparison of utilization from children with no apparent disability to children with special healthcare needs, as this study was done, goes up. For example, home health provider days are 95% more common than in the children with special healthcare needs than in children with no apparent disability. And healthcare expenditures and out-of-pocket expenditures are also higher. So the group of individuals with disabilities face common healthcare challenges. One is that there's been increasing specialization in our healthcare system, and that leads to fragmentation and poor coordination of care. We have vastly expanded the therapeutic opportunities. We were hearing today about stem cells as like a new wave opportunity, but we don't necessarily provide good guidance about which are the best options in general or for individuals. And importantly, insurance coverage, that's pretty important these days, as I'll go into in a moment, turns out in the US at least to be discontinuous, expensive, and inadequate. The challenges are magnified when we take a life course perspective. So the fragmentation, for example, is worse as children move from one stage, let's say childhood, into adulthood. We don't have good systems for conveying information and setting up new healthcare systems. In pediatrics in the US, we've been working to get medical homes so there's good care coordination for children and their families, but when these individuals go into adulthood, it's very hard to find similar systems of care coordination, though the American Academy of Family Practice is now buying into the medical or health home. So let's think a little bit about healthcare for children and also for youth and young adults with disabilities. So I think we first begin with our values and our vision. So let's take an example of an individual with Down syndrome. I would say that the old paradigm was that we initially thought about this child's health. So if a child like the case presented had congenital heart disease, we worked very, very hard to get that child as good a heart and circulatory system as was possible. After the child had healed from all of that, then we might be willing to allow restricted participation in something we call maybe a special education classroom or ultimately a sheltered workshop. And then if that child was really exceptional, we would invite inclusion into the community. In our modern era, I think we want to turn the paradigm on its head. Everybody deserves inclusion. Contribution is the ability to give to the society, the workplace, the family, as is possible, and we should conceptualize health in the service of inclusion and contribution. So inclusion is not a classroom or a school or an employment opportunity. It's welcoming individuals with disabilities into all aspects of community life, including family, school, employment, and neighborhood. And we should conceptualize this as a fundamental right for children and adults with disability. If we want to support contribution, we have to focus our care on improving functional capacities and not just clinical indicators. We have to identify treatments, services, supports, and accommodations that allow for full participation and contribution. And that means we have to integrate our traditional health approaches with education, with changes in the physical and social environment, and with attitudes, beliefs, and values, which have just been articulated this afternoon much more effectively by others than I could possibly do. So health, I would argue, should be conceptualized very broadly as a state of physical, mental, and social well-being. This is a definition promulgated by the World Health Organization. And what we should be doing is establish explicit target objectives to enhance function and quality of life as we fashion healthcare planning. To do that, we have to work in close collaboration, of course, with patients and families, but also with education, social service, and related supports. Now, I think those of us who work in developmental medicine, regardless of whether we're pediatricians, neurologists, surgeons, or others, and also as therapists, we have evolved in many ways in an ideal fashion to serve children with disabilities and their families. One important thing is that we work in interprofessional teams. The team we begin with is ourselves with our patients and their families, but then there are broad interdisciplinary teams within the clinic or the hospital, and the teams expand beyond the hospital to other services and agencies in the community. Importantly also is that we go beyond a traditional medical model. So in the traditional medical model, the individual has deficits, the physician and the healthcare team have solutions, and the recommendations go in one direction from those professionals to the individual. We recognize that individuals with disabilities are affected not only by their medical conditions, but also by social and environmental conditions. We try to identify strengths as well as needs. We engage the family and the individual in decision-making, and we use a wide range of interventions beyond medication and surgery, including environmental changes. I think the other thing that we do well in developmental medicine is we focus on the function of the individual, and we have some very, I think, impressive tools to help us with that. One that was a slide passed up this morning, so it gives me a chance to talk about it a little bit more, is the International Classification of Functioning, Disability, and Health. And I think this is just such a terrific contribution to all of us as healthcare providers. It shows that function is really represented at 3 levels of analysis. Body functions and structures represent function within the individual. Activity represents function of the entire person. And participation reflects the function of that individual in a larger social context. And the model recognizes that the health condition affects function at all 3 levels, but contextual factors, and particularly environmental factors that have been codified, and personal factors that have not been codified in the system, also affect function at all 3 levels. The International Classification of Functioning, Disability, and Health, or the ICF, does not prescribe measures, but rather a framework in which the evaluation of function can occur. So though we've done a good job in developmental medicine, I think there are areas for improvement. One area is team communication and team coordination. I can tell you that I work in a clinic that sees children with cerebral palsy and other other neuromotor and neuromuscular conditions. And in the last couple of months, I can think of at least 2 cases where children were scheduled for surgery by an orthopedic surgeon in a hospital system, disconnected from the therapies that were being done in the system that I was working in, and there was no communication. The therapist found out by happenstance, and therefore they weren't providing information, and they weren't prepared to support the child and family after the surgery. I think we have to pay really good attention to functional goals. The reason these 2 cases stood out was because the therapists weren't the least bit clear what the functional goals are, and therefore were really clueless as to how they were going to perform after the surgery. I would argue that we want to really start thinking about outcome measures that we can use cross conditions that are meaningful and that will allow us to demonstrate that our treatments are effective. There's been a lot of talk at this meeting about registries, or registers, I think is how it's described in other countries, and research based on these registries. And clearly, this group is extremely sensitive to the issues of implementing evidence-based practice guidelines as much as possible. Okay, so let's shift gears. In 2008, with the election of President Obama, and for the first 2 years of his presidency, there was a lot of talk about the failures of the US healthcare system to deal with many situations, and I would add to the long list individuals with disabilities. The result was the passage of something called the Patient Protection and Affordable Care Act of 2010, and in the news, you'll often hear it called Obamacare. So why did we need reform? So first of all, health insurance in the United States has really become an essential requirement in order to get health care. So just think about it, a trip to the emergency room costs hundreds of dollars, birth of a baby costs thousands, sometimes tens of thousands of dollars, and a stay in the intensive care unit might cost hundreds of thousands of dollars. So our ability to pay for the kinds of diagnostic capabilities that Dr. Ferreira has been talking about, or the fancy surgical approaches that we heard debated yesterday actually really requires health insurance. In the United States, the primary cause for bankruptcy is medical expenses. Now, unfortunately, despite this increasing need, these figures show us that the number of people in the US who didn't have insurance was rising. It's worth looking from about 1999 to 2008, the same methodology was used. And you can see that the percentage of people hovered around 15%, but as the population was growing, that number was growing and was approaching 50 million individuals. Despite that, the US total health expenditure per capita was the largest in the world. Here's the United States, next is Norway. We heard a little bit about Sweden is here, UK and Australia are down there. So we had the highest total health expenditures per capita, but we didn't have the best health outcomes. Here's one example. Infant mortality rates in Europe. United States is lagging far behind some of the other countries, including Portugal, Greece, and Italy, which we know have been having really hard financial times. So another important issue that the Affordable Care Act was responsive to was the changing in technology. So we know that there are many, many more computer capabilities than we had in the past. That's reflected in electronic medical record. That is allowing for some communication that before used to be very tedious. But at the same time, that change in information technology has meant that parents and individuals with various conditions have access to huge amounts of information and need more help sorting through the information than they ever did in the past. So I'm going to now outline for you the provisions that the law has in it and how they may relate to children, youth, and young adults with disabilities. So first is that the law requires universal and continuous coverage. To do this, it creates alternatives to the US system of employer-based medical insurance. And it does that in two ways. It sets up health exchanges where individuals can purchase health insurance on the market. And it also expands Medicaid, which is our public health insurance. It extends the age at which parents can claim dependence on their health plans to 26 years of age. And that's really important for a lot of young adults, like those cases, who might fall off and lose their health insurance at age 21 when they went, or 18 or 21, when they went from more of a pediatric-centered program to adult age. Also importantly, it prohibits exclusion from the health insurance on the basis of pre-existing conditions. So any one of those individuals who I reported before would have had trouble in the old days going from pediatric to adult systems because they would have likely been denied health insurance on the basis of the conditions that developed when they were children. It eliminates limits on annual and lifetime benefits, which is really important because that was a cause for discontinuous care. Many individuals met certainly their annual lifetime benefit, their annual benefit on a regular basis. And it prohibited rescinding of care when a person got sick unless there was evidence of fraud. So in terms of children, youth, and young adults with disabilities, these provisions of the law, I think, are worth an A+. The law also talks about the affordability of health insurance. And I think even though a lot of you in different countries have different systems of health insurance, some of these figures might be interesting to you in terms of how much people are expected to pay for their own care. So the law subsidizes the purchase of coverage and is provided on a sliding scale. Families up to 133% of the federal poverty level in the US pay no more than 2%, or I've heard recently 3% of annual income on their premiums, on their insurance premiums. And there's a maximum of 9.5% of annual income for premiums for families who are as much as 400% the federal poverty line. This is a big contribution. In addition, families whose incomes are less than 250% the federal poverty line are eligible for subsidies at the time of care, further lowering their total expenditure for health. So in terms of the care of children, youth, or young adults with disabilities, this is all, I think, really positive and worth an A+. The third category of provisions of the law relate to adequacy of coverage. And what the law has done is it defines essential benefits in 10 categories with an emphasis on prevention. If you look at that list of 10 categories, there are a few categories that I think are particularly important to those of us in the audience: rehabilitative and habilitative services, including devices, chronic disease management, and pediatric care. But the coverage has yet to be completely defined. So the challenges in implementing this law, which I think on paper looks really good for children and for individuals with disabilities, come from the fact that it was built with an adult medicine perspective, especially an older adult medicine perspective. So let's just think about what characterizes the population of adults, and especially older adults. First of all, it's a huge population. Second, among especially aging adults, there tends to be a few chronic or long-term conditions, such as hypertension, coronary artery disease, and stroke, and type 2 diabetes. And that accounts for the vast majority of adults seeking care within the healthcare system. By contrast, children have many more rare conditions, and almost by definition, people with disabilities have a wide variety of conditions. In the adult model, there was hopes for high cost savings in a really short time frame. Thinking about children or individuals with disabilities, that might be quite challenging because of the time frame of their conditions. And another thing that is really concerning a lot of planners in the US is that the Affordable Care Act seems to want to distribute health care services very broadly for ease of access to members of the population. And certainly if you have a large population and common conditions, having distributed networks of services really makes good sense. But those of us in pediatrics know that we have achieved far better rates of mortality and morbidity when we have regionalization of care. And I think a great example is neonatal intensive care units. So there's a lot of concern that there'll be tensions between this kind of general distribution of services for the adults, whereas we need to retain regionalization for children and individuals with disabilities, particularly those who have rare conditions. So let's think about children and young adults with disabilities in the era of the Affordable Care Act. There are a lot of uncertainties about what's going to happen. First of all, the nature of those essential benefits have yet to be defined. The way that the law has written it is that essential benefits are going to be defined by what was done in the past, by looking at plans, large plans that have been in existence. So if we think that coverage was inadequate and many needs were unmet in the past, the Affordable Care Act is not going to change that situation. There's going to be debates about the standard of medical necessity, and that's going to be very, very difficult to implement, particularly as we think about issues in disabilities. And again, we have to think about children, and we have to think across diagnostic categories to make sure that the adequacy of coverage represents a fair distribution. Another thing that's very uncertain in the next era is that new healthcare systems are going to be promoted via the Center for Medicare and Medicaid Innovation, and they have not been conceptualized with children or individuals with disabilities in mind. So one of the new structures in the US is called the Accountable Care Organizations, or ACOs. ACOs are supposed to be networks of doctors, hospitals, health professions of all varieties, and they share in both the financial and medical responsibility for providing coordinated care. So the idea is that the network, by virtue of co-membership, will make it easier for individuals to get the care they need. But anticipating that 50 million new people might enter the healthcare system as insurance becomes available to them, it's also really important that these accountable care organizations keep costs down so that the total expenditure per capita does not continue to rise. So the mechanism for that is incentives and bonuses, but at the same time to keep quality in mind. So the important thing to know for those of you in the US is that this is not a futuristic sci-fi kind of concept, that as we speak, there are at least 4 million Medicare beneficiaries and about 14% of the US population who are now being served by accountable care organizations, even though some people don't even know they're on them. So what do we think about this? Well, there's a worry. We've been through an era where we had health maintenance organizations that were designed to keep health costs down, and the way that they were most successful in keeping costs down was that they denied benefits, and it would be tragic to return to that era. There's also a concern that primary care physicians become a linchpin in this new program, especially for accountable care organizations, but they're underprepared for the role, just like they were underprepared for that role in the health maintenance organizations. A counterpoint that's better in this law than in the past is that the affordable care organizations do not require patients to stay within their network, although there may be benefits for staying in network. And the hope is that cost reduction is going to occur primarily by eliminating duplication and waste and reduction of unproven methods of care. So ACOs may be an interesting model going forward. I'm concerned that they retain mixed incentives. So hospitals and doctors are paid for procedures and hospitalizations. It's still a fee-for-service method, even though they're pushing for cost reduction. I can imagine that going forward that ACOs may require documentation of steps in an evidence-based medicine practice guideline before they would agree to procedures, especially expensive procedures. It's very exciting to be at this meeting and hear how much attention is going to creating systematic reviews, meta-analyses, and practice guidelines. But I think that means that innovative ideas or exceptions may be hard to get through in the next era. I think it's going to be very interesting to see how we balance financial incentives with person and family-centered care and shared decision-making. So it's easy to imagine that the families might or individuals might want to try procedures or treatments that are still not yet evidence-based. For example, we heard this morning about stem cells, and we're going to have to think about mechanisms to work within that tension. And ACOs must be developed that can respond to the diversity of conditions and the diversity of needs of individuals with disabilities. It's also, I think, important to think about ACOs and life course. So the transition from pediatric to adult care may actually be facilitated, especially if we create networks of individuals that include adult health care providers and that can receive our children and youth as they get older. And indeed, ACOs could create guidelines and quality measures that could specify when, how, to what extent transitions takes place at various stages along the lifespan. I'm also hopeful that maybe ACOs in the future can do some risk adjustment for payments or bonuses so that we can increase the provider pools. I think one of the challenges in finding adult providers for individuals with disabilities has been the lack of willing professionals. And that's because many individuals with disabilities require more time in care or are supported by public insurance, and the finances have not been seen as favorable to the professionals who care for them. But there may be opportunities if we have creative ACOs in adjusting payments to reflect those financial realities. One of the proposals on the table that I wanted to alert you to is that the Children's Hospital Association, which is the old NACRI, for some of you who may remember it under that label, is actually proposing an accountable care organization. And this would be a voluntary program for children with medical complexity. They're defining that as 2 or more conditions. And this is for children on Medicaid. So that turns out to be about 2 million children. What they propose is to create regional networks with children's hospitals as the anchor, and then to use national standards for care and for coordination. An important feature is that they'll want the networks to cross state lines, and that's going to take a little bit of change in our federal laws because Medicaid is very much a state-based delivery system. They're willing to share financial risks, and they're anticipating that they can save $13 billion in 10 years through this mechanism. So this is an example, I think, of a creative strategy for taking care of children who have high need over the long haul with functional consequences. I think one of the things that this proposal has to think about is the issue of transition, because it doesn't necessarily lead to smooth transitions for the very individuals we've been talking about. So where do we go from here? Let's maintain what's good in our current system. Let's retain our interprofessional teams in terms of their composition, their values, vision, and priorities for children, youth, and young adults with disabilities. Let's continue to use family and person-centered care and shared decision-making and really assure that that does not get eroded in future eras. Let's continue to use eclectic models of care, not a traditional medical model, and focus deeply on function and how we can support function. And let's continue to do collaborations with community-based resources and services such as schools, vocational rehab, employers, et cetera. We need to do improvements in areas of need. I would propose that we should think very hard about how to achieve greater bidirectional communication across all the members of the team. I think the EMR has made it easy for people to tunnel in and learn what happens in the hospital, and I think it's rare that we in the hospital go out and see what's been happening in the community. I think we have to have clarity about the functional goals for individuals. We have to introduce common outcome measures that we can record in the electronic medical record to document the impact of our interventions. We need to continue building registries and research networks and evidence-based practice guidelines. And then we need political engagement. We have to get or stay involved. And individuals is great, but more importantly as organizations. I was so excited to hear about the International Alliance of Academies for Children with Disabilities. I want to take a hats off to the Association for University Centers of Disabilities in the US. And I think we have to have even broader coalitions if we consider disability in that total broad perspective. We have to get to the table when laws are written, things like the ACA, but we have to stay at the table as regulations are formulated and implementations are planned. There are a lot of people who think that you have more political clout with regulations and implementation than you actually have with laws. And as we all know, the devil's in the details, so we might as well sit at that table. And then, of course, we need our organizations and ourselves to monitor the political landscape to prevent erosion of any improvements in care or in systems. So back to the take-home points. Let's build coalitions, maybe coalitions even broader than we thought we should, on behalf of children, youth, and young adults with disabilities. Let's evolve our healthcare delivery for individuals with disabilities to support inclusion and contribution in every step along the way. Let's impact regulation and implementation specifically of the Patient Protection and Affordable Care Act of 2010, but other laws and regulations in the various countries from which we all come. And let's become advocates and remain politically active to impact the direction of change. Thank you very much for your attention.